welcome to On the Media's very first live stream ever.
Good afternoon, I'm Joe Baker, a member of the Delaware Tribe of Indians.
Hello, and welcome to the 10th episode of Punishment and Profit, an educational webinar series about the prison industry presented by Worth Rises and the Green Space. I'm Bianca Tyler, founder and executive director at Worth Rises, a nonprofit organization that works to dismantle the prison industry and end the exploitation of those it touches. Today, we're talking about healthcare in the prison industry, from the spread of COVID-19 to the exacerbation of chronic health issues in our prisons and jails. Before we get into tonight's program, let's learn 5 quick facts about the healthcare sector to ground us. What would you do if a doctor poured sugar in your wound instead of stitching it up? My name is Bianca Tyler. I'm the executive director at Worth Rises, and here are 5 facts you should know about healthcare in the prison industry. Today, there are roughly 10 times as many people in prison or jail with a serious mental illness as there are psychiatric beds in the U.S. It wasn't until 1976 that the U.S. Supreme Court established a constitutional right to health care for incarcerated people, but it didn't set any standard of care, and little has been done since. Now, the U.S. spends $12 billion on correctional health care each year, a third of which is paid to private correctional health care providers. Many prisons and jails require incarcerated people to pay a copay to see a doctor or nurse, even for simple Tylenol. Given prison wages, the average incarcerated person has to work 25 hours for a medical visit. Still, the mortality rate of formerly incarcerated people is nearly 4 times the national average a year after they are released due to chronic illness like hypertension and diabetes. Learn more with the curriculum at worthrises.org. A little later in the show, we'll be talking to Dr. Homer Venters, Caroline Isaacs, and Marcy Croft. But first, earlier this week, I spoke to Sharon Edwards, who's serving a 20-year sentence in the Mississippi Department of Corrections after having completed a 20-year sentence in the federal system for the same crime. During the more than 2 decades that Sharon has been incarcerated, he has been an advocate for conditions of confinement. He's also the author of the recent Life's Lenses. Let's listen in. Sharon, when you were first transferred from the federal system to the Mississippi State prison system, you were in recovery from paralysis caused by a bacterial infection. At the time, you were taking medication and undergoing physical therapy to help restore your ability to do simple things like eat and walk. But when you arrived at Parchman, one of the nation's notorious plantation prisons, which contracts with Centurion for medical care, your care really changed. Can you tell us what happened?
Well, first, one of the head nurses informed me that I wouldn't be able to take the same medications that I had been taking in federal prison, and also that I would only be afforded 1 session of therapy. And the nurse, she was sympathetic to what I had going on, but she made it clear that because it was policy, she had to do that job, even though she wanted to help me. She was like, basically, if she entered the meds and if she asked for additional therapy, physical therapy, then they would likely deny it. So she had been through it before. And so what happened is I had to basically do all that I could to rehabilitate myself. And that involved like planks and simple things that I had learned during that 1 session prior to leaving federal prison and coming to state prison. So it was planks and sit-ups, like sitting up, doing sit-ups off of the bed, not sit-ups, but squats off of the bed, same way you would if you were in a wheelchair, to strengthen my legs again. And the planks was to strengthen my core because they emphasized having core strength. And it was a slow process, and in the process, my bones were still brittle. actually, and I was more accident prone because of that. So in the process, I ended up shattering my ankle. And so when I had that ankle, my right ankle, it was a 6-inch rod and some screws placed inside of it. Well, then there was another problem which came from the paralysis, and that problem ended up resulting in the 6-inch rod, like I said, but me not receiving but another one session of therapy. Even though I had rods, I had to learn how to do all of that all over again. I had rods in my ankle, so the walking process and all of that, it was a painful one. But they told me that Centurion would only allow them to give me that one session. And so also they just only gave me ibuprofen, and I'm allergic to them, so they changed that over to Tylenol, but they just couldn't give me anything. And in fact, Bianca, that leg or that injury that I had where it was shattered, I ended up getting staph infection. And so it was this big knot, like with the diameter of a thumb, that started growing. It was like yellow, green, white, but it was this big knot, and my ankle was swollen like the size of a loaf of bread. Well, they informed me that they couldn't do anything, so I made some outside calls, and they ended up giving me some shots. I don't want to mispronounce the name, but they gave me some shots, some booster shots that would take those down. But minus that, their hands were tied, and so it was basically like, you just heal if you heal, and if you don't heal, then we'll just have to amputate your leg or your foot.
And to be clear, Sharon, when the nurse told you that they couldn't give you physical therapy or they couldn't offer you medication, when she said that Centurion wouldn't approve it, she made it clear, right, that Centurion wouldn't pay for it.
Correct. She made it clear that they wouldn't pay for it. Right. They were not going to allot the funds to cover that.
What's crazy about that is that, beyond the unethical part of that, right, is that it ended up costing them more when you ended up having accidents and you needed to have that surgery and all these other pieces.
Correct. Yeah. So it actually costed them. Had they went ahead and done it in the beginning, I would have probably possibly never gone through what I had gone through with the ankle injury.
So you've spent time in both federal and state prisons and experienced different types of care. From your perspective, what is the difference between public and private prison health care?
Money. It just revolves around money, and when it revolves around money, the standards are less than they should be. Meaning, you're treated like you're on an assembly line. People just kind of rush you in and get you out. Federal is public, and state also. I mean, it's different. I can't give you the specifics and go and break down what's private, what's public. However, I do know that the healthcare isn't what it should be.
Right. Yeah, in Mississippi, the healthcare is provided by a company called Centurion, or at least was until very recently. And I think, that conveyor belt of care is, really awful. So, I guess I want to ask, consistently being denied necessary medical care has to be really taxing on the human spirit. What does it do to the human psyche, the spirit of those who are inside yourself and others, to be consistently denied basic health care?
Well, it puts you in a position where you have to just you wonder why people just neglect your health care because you're inside. So what it does to me mentally is it makes me feel as though people look at me as less than human. Not only that, but because we're incarcerated, I don't know, it just does something to you. It kind of breaks your spirit for a minute because you think like we're in this amazing country, and then here it is, being that I've come to prison inside this amazing country. The healthcare is not good because I'm inside and because they implement these policies that require just a minimal amount of assistance, medical assistance. And it kind of breaks you down. It kind of discourages you in the beginning. But over time, what I did is I just continued to try to self-medicate and do all that I could to make sure that I was okay, because I realized if I allowed that to determine the outcome of my situation, then it probably wouldn't be good. If I depended on them, it probably wouldn't be a great outcome. But it definitely destroys how you feel in the beginning. It does something to you. It makes you feel sort of helpless and just hopeless in a sense. In the beginning, you just have to hurdle that. So it definitely broke me down in the beginning.
So if the CEO of Centurion, which, for those watching, is a subsidiary of the publicly traded company Centene, if the CEO of Centurion or Centene were standing in front of you, what would you say to them?
We are human. We deserve to be treated like every other human in society, because at the end of the day, we are still human. We have the same rights, although we have committed crimes, most of us or some of us. We're still people, and you should treat us like people. You shouldn't treat us like a product. And that's the thing, they're treating us like a product, like commodities or something. We shouldn't be treated that way. We should be treated as individuals, and we should be treated on a case-by-case basis. Don't just throw us in there and give us one form of medication and say, oh, this is going to cover everybody in general. Just treat us like humans and take care of our medical needs, because we want to go home to our families.
Right. Sharon, thank you so much for sharing your story with us. I want to just note for the audience that you've served a 20-year sentence for carjacking in the federal system before you were transferred to Mississippi State Prison to serve a second 20-year sentence for the same crime. It's really unbelievable, but I understand that there are some bills currently moving through this Mississippi State Legislature and other conversations happening that may create a pathway to release you. We're praying for your freedom, Sharon. Thank you.
You're welcome. Thanks. Have a great day.
You too. To keep up with Sharon's story and learn more about ways to support his fight for freedom, follow Free Sharon Edwards on Instagram and Twitter. A quick reminder that if you're watching on Facebook or YouTube, please feel free to use the chat function to post questions to any of our guests. You can also post questions on Twitter using the hashtag #PunishmentProfit. Our next guest is Dr. Homer Venters. Dr. Venters is a physician, epidemiologist working at the intersection of incarceration, health, and human rights. Dr. Venters has recently been appointed to serve on the Biden-Harris COVID-19 Health Equity Task Force. Since April 2020, he has focused on addressing COVID-19 responses in jails, prisons, and immigration detention facilities. Dr. Venters is also the former chief medical officer of the New York City Correctional Health Services and author of Life and Death in Rikers Island. Dr. Venters, thank you so much for joining us.
Thank you.
So after security staff, the next largest budget line for most correctional agencies is healthcare. And yet we know that prison healthcare is awful, as we just heard in one anecdote from Sharon. It feels like we should be doing more, and that there should be more responsibility in that spending to actually ensure that people receive adequate care. Can you help us understand why prison healthcare is so terrible, even with well-meaning practitioners like yourself fighting to improve care inside? And if you could, offer some examples.
Yes, thank you, first of all, for the invitation to be part of this great discussion. I think that this is a complex issue, but one of the simplest ways to start the discussion is to remind ourselves that this whole area of healthcare in our country has been cut away from some of the most evidence-based structures and organizations that we have for everybody else. So that the people who decide what the scope of services will be for healthcare behind bars, that person or group is usually the sheriff of a county jail, or it's usually the commissioner of a Department of Corrections, or Homeland Security when it comes to immigration detention. We've left people who are security experts in charge of making decisions not only about what healthcare people should get, but also the really critical questions about when things go wrong, or when we say that we're promoting quality, how do we measure those things, and how transparent are we about reporting that to the outside? So the same standards that apply through the Department of Health or CMS to, let's say, hospitals or clinics, those don't apply to healthcare behind bars.
I think it's really interesting because like the first time we spoke, that was something I hadn't yet considered. The idea that there was billions of dollars, in fact, flowing into correctional facilities for healthcare. And yet it was like one of the few places where medical practitioners weren't actually making any of those decisions about how that money was spent.
I think that if you talk to a doctor or a nurse working in a jail or prison, they might push back. They might say, no, I get to do what I want. I get to take good care of the patients. And I think that a lot of the times that might be true. But if we look at how morbidity and mortality occurs behind bars, we know that the risks of incarceration aren't spread evenly, right? They accrue more to people who are people of color. They accrue more to people with behavioral health problems. And so if we look behind bars at the preventable deaths, for example, the jail attributable deaths, we would find that a lot of those happen to people who have behavioral health problems, because somehow it's okay to take somebody who's suicidal, for example, and lock them in a solitary confinement cell that has a different name on it. It might be called a mental health watch cell. Those types, or put somebody who's using treatment, undergoing treatment with methadone or buprenorphine, and throw them in a cell without that and force them into withdrawal. Those practices drive death. But because we don't have our state departments of health and our evidence-based structures promoting this and monitoring this, all of these things happen behind closed doors.
And the thing is that this isn't just about the acute impact, right? People who have been incarcerated have a mortality rate 4 times higher than the average person, even a whole year after being released. So what are the long-term implications of our healthcare failures in prisons and jails? And how do those implications impact not just the individuals who are coming home, but communities and the greater public?
Yeah, I think that we have no idea. We have not even begun to measure that, this long-term impact of incarceration on the health of individuals, families, and communities. Because I'll take one clinical scenario, which is blows to the head. Blows to the head are incredibly common behind bars. When I was at Rikers, we would measure blows to the head and traumatic brain injury, and we would report out statistics on that. Almost no jail or prison tracks or certainly reports that publicly. But if you think about all the blows to the head that are happening behind bars, you think about not just the short-term impact of what it's like to try and live with a concussion in a place where you're getting orders barked at you. You have to figure out how to survive on a daily basis. But think about the medium and long-term impact for relationships when people are going home with traumatic brain injury. And then think about down the road, the accrued risk of CTE that we hear about all the time with football and with veterans being concentrated in these communities. And so the other reason I bring up TBI is not just because it's a common health problem behind bars. It's that you can go to the webpage of the CDC right now and find all sorts of great information about TBI in youth sports and TBI in other scenarios. And I bet they don't spend one single dollar. I certainly have not seen any data or any efforts to either detect or mitigate TBI behind bars, even though it's one of the most common health problems that occurs among people. And it's a great example of the racism in health that we have in our national structure, in our best, highest organizations in this country, just leaving out these important health outcomes for people behind bars.
What I find so interesting about the anecdote that you present, Dr. Venters, is that it's not the typical thing we hear about the failures of healthcare behind bars or data, which is, the chronic health disease of hypertension or diabetes, but in fact, trauma, physical trauma that is enacted on the body by the institution, maybe by others, guards. What is it like, Dr. Venters, if I could ask, to provide health care in an environment where there is such an incredible amount of violence from the system done onto people, whether that's solitary confinement or that's physical assault, blows to the head, as you said, and try to provide care in such a traumatic space?
Well, so first, I don't want to minimize that there is inadequate care for chronic health problems across the board, almost everywhere I look. And so, people who have asthma, who are getting one a rescue inhaler when really they need a daily control inhaler. People with other health problems that need medications that don't receive them, or they don't receive them on a steady basis, so they don't get their level of control assessed. So the healthcare is substandard for chronic disease. I want to put that out there. That's my assessment. But I think another problem we have not even started to talk about is this problem of dual loyalty, which is, the health mission that you have as a doctor or a nurse or a psychologist or a psych tech to take care of the patient in front of you. That there's tremendous pressure on that by this security context. And it's not just big things like clearing people for solitary or pressuring nursing staff to look the other way to not document injuries. That happens. But it's little things like not ordering somebody a cane who needs a cane because a security person whispers something in your ear. This erosion of the health mission is a problem that's so prevalent. I usually compare it to infection control. We know there are germs everywhere in hospitals, and so we have to work hard to find and prevent the impact of germs on causing our patients infections. That is how prevalent and deadly dual loyalty is, because I see time and time again that when we find preventable death, what we find is that health staff stopped taking care of the person in front of them as a patient, and they started thinking of them as a malinger, as a liar, as a problem. They take on this completely different dynamic with them, and over and over and over that happens, and we don't ever talk about it. And so it is really a difficult place to provide care. But if you work for a for-profit vendor, or if you work in a place where nobody talks about these issues, then it is for sure the case that when the patient comes along that you're going to be more likely to make these mistakes with, that's going to happen.
Yeah, wow. We have a real commitment to that false sense of security, right? So much so that we can watch people suffer really grave harms. Dr. Vendors, you've done an incredible amount of work on COVID-19 in prisons. New York Times came out with some numbers over the last week, specifically saying that people in prison, incarcerated in this nation, are 4 times more likely than the average person to have contracted COVID. Can you talk a little bit about why that is and what the implications of that may be in the long term?
Sure. I think, first of all, as the Times kind of allows for, but I'll just say it explicitly, those numbers are a gross undercount. I've done about 24 or 25 COVID inspections, like court-ordered inspections to see what's going on with COVID in jails and prisons and ICE detention settings in the last year. And everywhere I go, there are scores of people, many housing areas where COVID ran through and nobody was tested, or just a handful of people were tested. And so there are a lot of people who experience this infection that we don't know about. There are also, I think, people who died from COVID that haven't been accounted for correctly. The consequences of this incredibly high rate of infection, morbidity, and mortality, are profound. I think that, first of all, most of these places are not actually making any effort to find the people who have long COVID, who have persistent symptoms. So people actually may be going home with kind of new disability or ongoing chronic health problems from having experienced COVID. But I think then one step beyond that is, the incredible trauma that people have shared with me about being locked in a housing area as COVID rips through. People are getting sick, some people dying. People are doing their best to care for each other while they may not be able to even care for themselves or protect themselves. And then they may be in a place where the correctional staff or the authorities in the place not only don't take it seriously, but they tell a completely different story, an untrue story about what's happening. And so that is really traumatic, from what I've heard from and learned from people. And I think that trauma, people take that home with them.
Right. So to close out here, I think this, in our conversations, COVID in particular may have opened the door, though with the CDC and Department of Health and Human Services, as you mentioned earlier, for decades, these agencies have done little to regulate or even collect data around healthcare in our nation's prisons and jails and the health of people who are incarcerated. But this catastrophe of the pandemic and the havoc that it wreaked on facilities seems to be starting to change that. So can you talk a little bit about how the CDC is now understanding correctional healthcare to be an issue of public health and what this means for how things might change going forward?
Yes, I think that I'm hopeful. I think that, the CDC not only has been involved in promulgating these standards, these detention standards since March, it also has been going through its own kind of introspective discussion about racism and health and what are they going to do to really address racism and health in this country. And so with those two kind of issues at play, my hope is that the CDC establishes a real Office of Detention Health or Correctional Health, that it gets involved in tracking all of these health outcomes and promoting better health outcomes for people behind bars. And critically, that they start working with state departments of health. Not every state department of health will be interested, but some will. And so working so that we can bring these health outcomes and promoting better health care into kind of our national construct for healthcare, because this stays hidden. I think that's one of the really powerful silent capitulations that allows mass incarceration to continue. And I think that if we get health systems, health insurers, hospital systems, and departments of health to understand how devastating and how harmful incarceration is to health, I think those are really important voices. And so we can start by leveraging this little bit of interest we have from the CDC in COVID right now.
And it's wild because even in these last few days, one of the simplest things, right, was just a new classification, or at least including prisons and jails, right, in the classification as a congregate setting. Something that would have seemed really obvious to probably the lay person, nursing homes or congregate settings, but that wasn't something that prisons and jails were labeled as, and that in and of itself could help.
Yeah, my hope is that by having that explicitly in the task force recommendations from this past Friday, that can help promote this idea that, if you don't explicitly include jails and prisons in your definition of congregate settings, and then prioritizing vaccines, testing, everything else that comes with that, then it should be clear to everybody what you're doing, which is you are explicitly ignoring science that, as we know more than well enough how devastating the virus is in all congregate settings. And so my hope is we can, at least with some of the states, start to get a better understanding and a better practice in that area.
Dr. Venters, thank you so much for your time and for all the work you've been doing across the country to protect the health of our people inside. We'll see you at the end of the show.
Thank you.
To learn more about Dr. Homer Venters' work, follow him on Twitter at Homer Venters. Next, I want to bring in Caroline Isaacs. Caroline is the program director for the American Friends Services Committee's Arizona office. Caroline has worked for over 20 years advocating for just and effective criminal justice policies in Arizona. She's authored several reports on private prison corporations, conditions in correctional facilities, and criminal justice policy and sentencing, including the treatment industrial complex, how for-profit prison corporations are undermining efforts to treat and rehabilitate prisoners for corporate gain. Welcome, Caroline.
Thanks so much for having me.
So more and more correctional systems appear to be privatizing healthcare, right? We've just been speaking with Dr. Venters about the kind of the general state of healthcare in our prisons and jails, but we also know that this is being increasingly influenced by the privatization of healthcare in prisons. Your home state, Arizona, has gone through quite an experiment with privatized prison healthcare over the past few years. Can you tell us about that history, the before, during, and after of privatized prison healthcare, and what the impact has been?
Absolutely. So the push to privatize in Arizona came directly from the state legislature. And in 2010, the state budget included a requirement that the DOC put out an RFP to privatize correctional healthcare. It required that the bids come in below the cost of medical services in 2007. So unsurprisingly, the department got very few, if any, bids on that contract because no company can deliver adequate care for so little money. 2 years later, the legislature had to remove that language from the bill. And this is particularly telling and underscores part of the fallacy of privatization as cost savings, because certainly the sales pitch at the time was to privatize healthcare was to save the state money. But state legislature chose to move forward with the plan, even if there would be no resulting cost savings. A second RFP was issued in 2011, 2 years later, stipulating that it be awarded to the most qualified bidder. So while that RFP process dragged on for 2 years, many state prison medical staff resigned because they were concerned they wouldn't be hired by the new contractor. Vacancies became a problem. And then fewer doctors and nurses meant longer waits to be seen, treated, receive medications. And the department was reluctant to send people out to specialists or do expensive surgeries because they were waiting to hand this stuff off to this private operator. So incredibly, during those 3 years, healthcare spending in our DOC dropped by nearly $30 million. As a result, in 2012, there was a huge class action lawsuit against our Department of Corrections over the dismal state of medical and mental health care in our prisons. So it's worth noting, right, that timing of all of this, that this very process of privatization and the related delays were a major contributor to those terrible conditions. And the timing of that lawsuit means that we have an unusually clear window into the absolute debacle that followed. Usually, a real problem with this is often the unaccountable nature of medical care and everything else that happens in correctional facilities. But because of these legal proceedings, there's a level of scrutiny that rarely exists elsewhere. So the way that this the whole process played out is very interesting as well. You know, after this long drawn out saga, finally a contract was awarded to a company called Wexford in 2012, and literally a month later, one of their nurses exposed 103 people at one of our state prisons to hepatitis C by misusing a needle. And health officials for the state were not told this for over a week. So it's clear that the department maybe hoped that privatization would shift some of the responsibility for the lawsuit onto the contractor. That didn't happen. And so then it became this back and forth between handing it off to a new private contractor. So in 2013, the department took the contract from Wexford, gave it to Corizon. And that clearly did not do the trick either, because the settlement in that class followed in 2015. And in 2018, our Department of Corrections was held in contempt for failure to comply with that settlement. So here's the key, one of the key takeaways here is privatization creates a situation in which both the state and the private contractor are passing the buck back and forth to each other, and neither is really taking responsibility for fixing these problems or doing anything about them, really. So we've got I'm sorry, go ahead.
No, go ahead. I'll let you finish.
So we finally have a third contract for medical care that was awarded in 2019. And that is Centurion, who we heard earlier in the broadcast from Sharon's experience with in another state. So his experience, of course, is not at all uncommon. We hear very similar stories here. And in the meantime, last year, our department was found in contempt for a second time in that lawsuit. So contracting out medical care here has resulted in more bureaucracy, less efficiency, and decreased quality of care.
So, and we're going to hear more about Centurion too with our next guest, Marcy. But, you know, it reminds me a few weeks, or actually just last week, we had a conversation around food and commissary, and there was a similar sort of experiment done with privatization of food service in Michigan, for example, where they rotated through 3 different private vendors for food service. And it sounds like Arizona is going through a similar experiment with privatized healthcare over the last number of years on its 3rd vendor, and that likely isn't going to produce anything much better. So, you know, I think just recognizing what you were saying, which is not only, you know, that these private vendors don't often actually save states, counties any money, but they also cut costs to such a devastating perspective that we're constantly in lawsuits, constantly in new procurement processes, and these opera rotations. So, Caroline, your report from a few years ago began to give us a picture into how many prisons and jails across the country had privatized care. And at the time, it was more than half. Can you help us understand why prisons and jails have moved towards this privatization? And is that trend continuing, especially given everything that we're seeing in states that have had really big debacles with privatized prison healthcare?
The trend certainly has continued, although it is very difficult to get data to gauge the full extent of privatization across prisons, jails, and other types of contracts, although Worth Rises is doing an amazing job of trying to gather that data for the general public. Even when major news organizations are trying to investigate these issues, they get partial or conflicting information. But it's certainly clear that this is not something that's slowing down or stopping. As to the question of why, that really is the crux of the issue, because if the stated reasons, the sales pitch of cost savings and efficiency are obviously not being delivered, then what's really going on? We all know there's no such thing as cheap medical care, least of all in prisons and jails. The only way to save money, and I might add, in the case of privatization, make money on the top of that, is to cut corners and deliver shoddy care. So as you mentioned, that's when people get sicker and we need more costly interventions and governments get sued, hopefully. But anyone who's worked with elected officials knows that facts matter far less than belief. And certainly in a state like Arizona, many elected officials believe in privatization. They believe that corporations can always do better than the big bloated government bureaucracy. And the facts just don't seem to make a dent. Another thing that's interesting and indicative of our experience here, how the market continues to grow in spite of the terrible performance of these operators, is, when a contractor fails abysmally, states don't just say, we're going to take it back. We're going to go back to providing our own in-house medical care. They find another operator. Because once all these things have been outsourced, it's incredibly difficult for a state agency or a county or what have you to build that infrastructure back up. So they're basically over a barrel. And that provides like a real advantage for these corporations to come in and say, well, that other company screwed it up, but we're going to be great. We're going to do all these things differently. Oh, and by the way, the per diem will be twice as much so that we can provide you with this better care. And Arizona still hasn't learned that one after 3 times. The final thing I'll say that is not to be overlooked is that these corporations are extremely well financed, and they invest a ton of money into lobbying and campaign contributions and shuttling key players back and forth between the public and private sector. So they are working day and night to enhance that belief that many elected officials already have, that privatization of correctional medical care or practically anything else is a great idea.
Yeah, I think it's super, that belief thing, I think is such a strong point, right? That data doesn't matter. It's not actually true, but you're going to believe it. And in fact, and this is going to take us to the last question, there was recently a study done in Delaware County, Pennsylvania, which just moved to actually deprivatize its jail. And this is, related not just to private healthcare, prison healthcare, but the entire operation of the facility. And, the argument for so long was about insurance, right? As you mentioned earlier, keeping insurance liability to the private corporation, and that the private corporation, made running this jail cheaper. And of course, they just did an independent economic analysis that found that that's not at all the case, and that the county is actually going to save a ton of money by deprivatizing their jail. Which takes me to my third last question, and we're running out of time here a little bit in the segment to ask. But it's not just private correctional healthcare corporations that are the issue. It's also now that private prison corporations are marketing their services as treatment. And this is probably most egregious example of what Dr. Venters was saying when he talked about funneling money, around healthcare into the hands of correctional institutions, in this case, for private prison operators in making these decisions. How is this changing the landscape?
Of the massive incarceration industry in this country is a potential growth area for some company. They are selling whatever they think states are buying. So in previous decades, it was lock them up, secure facilities to manage the explosive growth in prison populations. Now, after 10 plus years of sentencing reform efforts and a very different national discussion about what the purpose of corrections is or should be, they've softened their image and they're rebranding as providing treatment and rehabilitation and reentry. If you're Geo Group, second largest private prison company in the world, it's a really smart business move to grow an entire division called Geo Care. And I'm not making this up. This is an actual thing. And here's what your webpage is going to say, because this is what their webpage actually says. Our full continuum of recidivism reduction programs is designed to help stabilize individuals in the community and support their successful reintegration. So basically, they literally call this the Geo Continuum of Care. And what it means is that this company is going to extract every ounce of profit from a person by having some role of custody or control over them for as long as possible. So they're going to provide some rehabilitation services while that person is in a Geo-run prison. And then that person's going to get transferred to a Geo Care reentry facility or released with a Geo GPS ankle bracelet monitor to some form of community supervision. And then that monitor will beep if they step outside at the wrong time or they have a beer if they're not supposed to, and they could possibly get revoked back to another Geo facility and start the cycle again. At the top of the program, Sharon really laid it out very clearly. The difference between public and private prison healthcare is that it's about money. And the purpose of these corporations is not to help people or treat their illnesses or reduce recidivism. It's to make money for their investors. And that business model is and will always be directly at odds with the goals of a legitimate healthcare provider, which is to make people well.
Caroline, on that note, thank you so much, really, for the work that you're also doing. To keep up with Caroline's work, visit afscarizona.org. We'd like to remind everyone that you can share questions in the chat on YouTube or Facebook, or by using the hashtag #PunishmentProfit on Twitter. We'll be taking your questions at the end of the program. Our final guest today is Marcy Kraft. Marcy is the lead lawyer representing hundreds of people who are incarcerated in Mississippi in civil rights and wrongful death actions against the Mississippi Department of Corrections and its vendors. Partnered with Rock Nation, Marcy and her law partner, Jessica Rice, are working within their all-woman-owned firm, MJ Legal, to correct decades of mistreatment and inhumane living conditions at Parchman Prison, the Mississippi State Penitentiary. Marcy, welcome.
Hi, Bianca. Thank you for having me.
Thanks so much for being here. So, Marcy, you recently sued the Mississippi Department of Corrections and its privatized healthcare provider, Centurion, the name we've heard a few times, for providing substandard care. Can you explain the claims in that case? And if you can you please give us a few examples about the general state of healthcare under Centurion in Mississippi and Parchman, and how its for-profit model exacerbates that situation?
Yeah, absolutely. We worked with Team Rock and Rock Nation and hundreds of people incarcerated by the state here in Mississippi to uncover the unconstitutional conditions that exist at Parchman Prison, which is our main state penitentiary here. And as part of that, we ended up having to sue Centurion and the Department of Corrections. Centurion at the time was the healthcare provider here in Mississippi. And whether it was Dr. Venters or Caroline earlier, I've heard some of the horror stories, that they have seen. And sadly, we have hundreds of examples that are similar to those coming out of Parchman. And of course, your first interview today really exemplifies that, right? So what we've seen is just completely substandard care by Centurion. The fact that it is a for-profit corporation, it really is part of the problem. If you think about it, our state pays Centurion per incarcerated person per day. And Centurion, like any other company, it's got one goal, that's to make money for its shareholders. So it tries to bring in as much money as it can, and it tries to spend as little as possible. And on the spend as little as possible part, that means give as little care, put as little expense upon there as they can legally get away with. And sometimes, unfortunately, unconstitutionally and illegally get away with. And that's what we've been dealing with here in Mississippi. Luckily, mid-July of last year, after we filed suit against them, they announced that they were no longer going to participate in healthcare in Mississippi, prisons and jails. And our Department of Corrections actually hired a new vendor just this past fall. But for a year, we have been fighting them and the horrors and the damage that they've left behind on Mississippi citizens that have been incarcerated.
So, Marcy, let's talk a little bit about how this case emerged in the first place. It emerged out of what was a violent outbreak in Parchman, which we should say for the audience is also one of the nation's notorious plantation prisons. As you know, it is also where Sharon was denied care. Can you talk a little bit about or explain how this case emerged from that particular incident? One that, was, for those of us who are involved, quite horrendous.
Yeah, absolutely. At the beginning of 2020, there were a number of riots that occurred at Parchman Prison. Our state government liked to blame that on gang violence or on anything else that they could think of, cell phones being present in the prison, things like that. The reality is what you had were thousands of people locked up in unsanitary, unsafe conditions, without enough food, without enough water, not allowed to shower, not allowed to go outside. And the death rate at Parchman began to skyrocket. In fact, I think earlier someone mentioned that if you've been incarcerated, your mortality rate is increased by like 4 times, right? Well, at Parchman, the mortality rate is twice that of the average jail in prison. So for people in Parchman, it's 8 times the average person. If you think about that, if you're inside Parchman, you are 8 times more likely to die. And that certainly should not ever be the case. So that's really the conditions we have been fighting. And those riots in reality were caused by those poor conditions. If you locked everyone up on this discussion here this evening, right, for a year without enough food, without enough water, without the ability to go outside, with, showers rarely at best, we would all get violent with each other. That's understandable. But the reality is there aren't enough guards up there. They didn't have enough people to even let guys out of their cells to go shower. They couldn't get them to medical. So oftentimes treatment was denied and simply marked down as refused. And of course, in the prison world, they get charged $6 every time they have a sick call. A sick call is a little form they want to fill out. If they need to go to the clinic for any reason, they're going to get charged $6 for that. And we saw a trend where guards over and over would mark refused to go to treatment. And sometimes they would still get charged their copay, even though the guards just refused to come and get them out of their cell. So it was a completely broken system there at Parchman. Untreated wounds, untreated injuries, head injuries, a number of suicides. The mental health conditions there are abysmal. It really was just and still is a very difficult place, but it was as close to hell as I've seen on earth. Was Parchman, January of 2020.
You mentioned copays, right? I think most of our viewers may not know that people in prison actually do pay copays to go to a sick call, as you said. In Mississippi or in Parchman, it might be $6. Other places it's $3, other places it's $13. But I think what people should understand is that amount, is not comparative to our existence here on the outside. For the average person who's incarcerated, a sick call costs 25 hours of work.
That's right.
Because of the rates that people are being paid on the inside. And we, in fact, consistently hear, particularly when it comes to private corporations not wanting to provide real care, and dismissing people with a Tylenol, right, or some kind of pain reliever, and now you've spent $6 on Tylenol, and so yeah, it's something that I think a lot of people just don't know.
Absolutely.
I'll also say, so it's important to know that Centurion, right, which is like a name that most people might think is completely obscure and have never heard of, is actually a subsidiary of a $36 billion publicly traded managed care company called Centene. Centene is, as we've just known, publicly traded. It's massive. And this isn't a residual corporation that they've owned for some time and just can't get rid of. They bought into this industry in the last couple of years. And now after you sued Centurion, Centene pulled Centurion out of the Mississippi prison system, as you mentioned, and they claim that, they weren't being paid enough to provide adequate care. Is that really all it was?
No. is the easy answer to that. Absolutely not. First of all, they were paid upwards of $50-60 million just from the state itself, right? And they certainly had enough funds to take care of the individuals of whom they were put in charge. They just chose not to do it. They chose to maximize their profit. That's what corporations do, and this argument that, well, corporations always do things better than the government, maybe that is the case in certain instances, but what corporations are required to do, what they're supposed to strive to do, is make money for their shareholders. And in this instance, making money for their shareholders and providing adequate constitutionally required care are in opposite of each other, which is why for-profit prisons shouldn't exist, and for-profit vendors with respect to prisons just shouldn't exist. Companies should not be making money off of us locking our citizens up, period.
Marcy, thank you so much. Thank you for the litigation work that you're doing. To follow Marcy's work, follow her on Twitter at Marcy B. Croft. If you haven't yet, now's the time to drop your questions into the chats on YouTube and Facebook, or on Twitter using the hashtag #PunishmentProfit. But before we jump into Q&A, as always, here are my takeaways from this week's discussion about healthcare. Prisons are not made for care. Or as our previous guest, Eunice Hernandez, put it, you can't get well in a cell. And yet we funnel billions of dollars for healthcare into prisons and jails every year, where correctional administrators and corporate executives have the upper hand above medical practitioners to make decisions about how we care for people. And it's not shocking that private and public prison healthcare corporations and agencies are regularly sued for malpractice, but it's sad that courts rarely condemn failures and allow them to persist. Our neighbors come out no better for it. In fact, their physical and mental health are left worsened by the food served that lacks nutritional value and is high in sugar and sodium, as we learned last week, by the lack of preventative medical care for chronic health that leaves them dying of hypertension and diabetes upon release, by ignoring the massive spread of a deadly pandemic, and made worse by all aspects of prison living, or by the lack of attention paid to even acute injuries, sometimes traumas faced within that environment. Just the other day, there was a report of someone who passed out in a prison where it took 9 minutes for officers to respond, and when they didn't even bother to provide CPR. It does something to people to know that others are gladly watching them suffer, that their health and pain can be dismissed, that you can prevent them from dying and yet approach without urgency. There's also the trauma of physical beatings, threats of violence, and solitary confinement wielded under the guise of security. There's the lack of substance abuse programs, which make overdoses the leading cause of death for the first 30 days after release, during which people returning home have a mortality rate 12 times that of the average person. And let's not forget groups that require special care, like women, transgender folks, and our elders. With more people serving life sentences than ever before, the prison population is aging. We have people at 60, 70, 80, and even 90 years old behind bars for crimes committed decades ago. I heard a correctional commissioner once say in a closed-door meeting, "I want to let this guy out and I can't. He's dying from cancer, so I make special arrangements for his daughter to come see him every day. He can barely sit up, but society is still scared that he'll pick up a gun with his last dying breath." Our irrational risk aversion is making life harder for my staff, is costing us a fortune, and it's just cruel. I was surprised to hear him say that, but he was right. We're so committed to punishment and irrational perceptions of safety that we kill people, and those we don't put to death, we watch die a little bit slower. And with that, now let's bring back all of our guests to answer some of your questions. Hey everyone, thank you so much. And of course, unfortunately, Sharon cannot be with us as a result of his incarceration. So we have a few questions that I'm seeing pop up, and we're probably only going to have time for about 2 questions, but I have some good questions here. And the first question I'm going to relate to Dr. Venters. This question is from Stacy Burnett. There is a COVID-19 outbreak in the New York State women's prison facilities right now. What should we be asking to improve conditions and prevent more spreading if clemencies aren't being granted?
Well, right now, I think that one of the most important things happening in New York State docs is the recent court order mandating vaccination. And so what's important to ask is not just how many vaccines have been given, but what percentage of people who are in each facility have been fully vaccinated? And beyond that, what percentage of staff have been fully vaccinated? So there's a lot we need to do to engage with people to promote vaccination. But in New York, because there was this fight, it had to come down to this legal fight. The question I have for each facility I go to is, what percentage of people have been vaccinated, not just among detained people, but among staff?
Thank you, Doctor. The second question, I'm going to throw this to you, Caroline. This is from, and excuse me if I do not get your name right, Francesca Bluher. In the healthcare, is the healthcare in both private prisons and federal state operated prisons for profit? So what's the difference, essentially, I think the question is getting at, between a private prison and private healthcare? And can the two overlap in facilities?
They do. So there's all flavors of privatization. So sometimes a private operator will have its own contract, a subcontract with another private company to provide medical care, or a state-run facility has, here in Arizona, some state-run units are also operated by for-profit companies, some are not, but the entire state medical system is privatized. So it really depends on the jurisdiction. The contracts are signed with a government entity for any range of programs and services. So it varies widely.
Thank you so much, Caroline. And that's all we have time for today. I want to thank so much to all of our speakers today, Sharon Edwards, Dr. Homer Venters, Caroline Isaacs, and Marcy Croft. And thank you to all of you at home for joining us. We'll be back next week at the same time, Tuesday at 7 p.m. Eastern, to talk about transportation. For those who want to keep tonight's conversation going, to ask more questions or share your reflections, join us as we head over to Clubhouse for our public study group. Follow me at Bianca Tylik to find the room. If you'd like to learn more about or support our work at Worth Rises, please check us out at worthrises.org and follow us on Twitter and Instagram at Worth Rises. I'm Bianca Tylik. Good night. facilities for healthcare, and yet it was
or conflicting information.
And that if you've been
administrators and corporate executives